Faisal Rahman here from the Department of Medicine, for those of you who don't know me. I hope everyone is doing well and coping well with our current struggles. Today, we're lucky to have Dr. Paul Cameron as our presenting professor. So Dr. Cameron graduated from the critical care program here at Western University in 2020, just recently, after completing his internal medicine training at Dalhousie. He's involved with home mechanical ventilation, the program, along with Dr. David Lisa, as well as heavily involved in the clinical care of the medical surgical ICU patients and the cardiac surgery recovery unit patients. And today he's going to be talking to us about the management of our patients suffering from coronavirus infection in the medical surge ICU. So without further ado, I'll hand it over to Dr. Cameron.
Thank you, Dr. Rahman. As mentioned, I am one of the intensivists who works predominantly at MSICU, and I'll be talking about our experience in the ICU. As I saw from Dr. Devlin's talk last week, I understand it's mandatory to have a Zoom joke at the start of everything, so here's mine. I want to start off by showing a picture that came to us from the Twitter sphere. So this is a patient in New York City, and I think it should be a nice, calm, relaxing start to the talk. Here you can see a patient who, because of comorbidities, had elected to not pursue invasive life support. So they were kept monitored without proceeding to invasive ventilation. And what may give some people some element of angina here is seeing a saturation of 44% with a relatively preserved waveform. However, this is not really accompanied by hemodynamic compromise. You can see a normal heart rate and borderline blood pressure. However, this patient had cirrhosis. And most importantly and curiously, the respiratory rate is only 22. So this kind of gave people quite a bit of pause and asking questions. This is supposed to be COVID, this is supposed to be pneumonia, this is supposed to be ARDS, but most patients we see with saturations of 44 are working a little bit harder. So I'll get back to this and explain why this informs our decision-making in a second. I wanted to also point out that I'll try to avoid some of these pitfalls, the 7 deadly sins of PowerPoint, and I'll make note of the ones I'm intentionally violating, but people can chat at the end about which ones I missed. So to get back to the physiology, early observations in Italy as well as New York City have found this profound hypoxemia that's not associated with an increased work of breathing. And after a number of patients have came through, especially in Italy, one of the godfathers of invasive ventilation, Gattinoni, came up with this phenotyping system. So the hypoxia that we see in COVID pneumonia seems to be multifactorial. The easiest one to understand for us is the third star here, which is pulmonary edema and collapse in an ARDS-like fashion. However, many patients don't seem to fit this phenotype, both radiographically and clinically. And we see a predominance of hypoxemia on the basis of impaired hypoxic vasoconstriction, and there's been the possibility raised of pulmonary microthrombosis, which we see potentially reflected in the elevated D-dimers. So Gattinoni and the European Society of Intensive Care Medicine, where this infographic comes from, have subdivided patients into 2 phenotypes. We have phenotype L and H. I'll start with the H phenotype because it's the most easily transferable from our ARDS understanding. The H stands for high. So we have high elastance, which is the inverse of compliance. And this is on the basis of increased alveolar water, which displaces air and leads to lower compliance. So these patients have a high ability to be recruited. They have a right to left shunt through all of the atelectatic or collapsed lung. And they'd also be predicted to have a better response to PEEP. Now, the patient I showed at the beginning with the profound hypoxemia but low work of breathing would probably fit into this L phenotype, which is low everything. So low elastance, low VQ matching, which is proposed to be on the basis of the impaired hypoxic vasoconstriction, and low recruitability. So they should have not much response to PEEP or the other maneuvers we do in the ICU. The other observation from Europe has been the phases of this disease. So some patients present in a spiral, which is considered the hyperacute disease, with profound hypoxemia and breathlessness leading to immediate need for invasive life support. However, there is a subset of patients who are presenting with more indolent courses that have some element of work of breathing, but it seems to be single system and it's predominantly hypoxemia. And they may linger like this. They may get intubated or linger for 3, 4, 5 days and actually start to look better. And this is important for us because they start to look fairly compliant on the ventilator with minimal oxygen requirements. But then we've seen a number of patients locally at our center who fit this categorization, and is followed by this second biphasic component with a huge inflammatory response and multi-organ failure. So you can understand we've extubated a few patients in the indolent phase only to require reintubation in this secondary biphasic spiral. And the reason I spend so much time on this is because it informs our decision analysis for managing these patients. So now I'll talk about the variety of respiratory supports that we're using for these patients. So this is a draft flow sheet from earlier this week. You can see that I'm committing SID number 7, which is an overly complex diagram, but I'll break this up in further slides. And we'll start off by showing the far left panel. So I think the majority of patients, especially in internal medicine, would come into the emergency department or be on the ward with an acute respiratory illness, have some element of hypoxemia, and then COVID is either confirmed or suspected. So obviously the management of these patients involves supplying oxygen, either by nasal prongs or face mask. And then the first decision branch point is going to be whether they can maintain adequate oxygenation on an FiO2 of less than or equal to 40%. Again, this will be most patients. If they can, the recommendations are to isolate the patient in a single room, if there's a negative pressure room available, to use this, and that providers would need droplet and contact PPE. In the subset of patients that do not maintain oxygenation on 40%, the next slide will outline their management. So the first branch point is fairly straightforward. If we have patients who are hypoxic and have evidence of multi-organ dysfunction or shock, they would go on to require intubation. Intubation, not surprisingly, is considered an AGMP or aerosol generating medical procedure. So these patients will be moved to a level 3 unit, ideally. If there's a negative pressure room available, they would be placed in there. Patients will have providers associated with them in enhanced droplet and contact. And sometime in the next week, we should have intubating teams comprised of anesthetists and emergency physicians who will come and perform the intubations for us. If patients are not in shock or multi-organ failure, the next question we're asking is whether they have a primary hypercarbic disease or one that would normally respond to non-invasive ventilation. So even in patients who are suspected or confirmed COVID but have a history of COPD or neuromuscular disease and present with respiratory acidosis, and similarly patients who have evidence of acute cardiogenic pulmonary edema, we are going to consider these patients for non-invasive ventilation, specifically bilevel positive pressure. BiPAP, as I'll describe later, is also an aerosol generating medical procedure, so it would have the same precautions. If patients are able to be admitted to a level 2 or 3 unit, again in negative pressure, this would be preferred. And we expect that respirology, CCOT, or ICU will be involved depending on the site. So some patients will not have a primary hypercarbic disease, and what do we do with them? So the next screening criteria would be looking at those patients who might fit the L phenotype. So patients who are not acidotic, have relatively low work of breathing, and are awake and alert. We would consider these patients for high flow nasal cannula oxygen or CPAP. This is similar in terms of precautions and ward management in terms of where they'd go as BiPAP. And then the question becomes, how do we follow them? So the two of the 3 metrics, I guess, that we'll be using would be a target of a PF ratio over 200 if they have arterial blood gases, or if they don't, an equivalent measurement would be saturation of oxygen to FiO2 of greater than 235. If they meet this target, then you can see they'd go over to be observed, and we would monitor their respiratory rate oxygenation index, which I'll get to. And if they don't meet this target, the next step is considering prone positioning in patients on high flow, which is something that we don't have as much experience with as prone positioning invasively ventilated. So I mentioned that BiPAP is aerosol generating, and this is a fairly provocative figure that shows the way in which this happens. Because BiPAP is applied through a oronasal mask and is sealed, patients would be at risk of rebreathing carbon dioxide if the mask or the circuit was not vented. So we have exhalation ports in most of the ResMed disposable masks that we've used up until this point, which expels exhaled air. And here you can see the plume of aerosols that are generated from this. So this is clearly not ideal in a prevention of contamination situation. So we've made some modifications to the BiPAP we'll be offering. This is our Stellar units, which we use on the wards as well as in the home program. And the modifications, which you can see, firstly, there's a non-vented mask. So where previously there'd be exhalation ports, we switched to non-vented masks. Right at the first bracket, there'll be an anti-asphyxia valve, and this is so that if the machine stops working for some reason, patients can still breathe past it. This will be followed in series by a viral bacterial filter and humidity and moisture exchanger. And then the exhalation port is the most distal, so that there still will be aerosol generation, but it should be filtered. The second thing I wanted to mention was the ROX index, or respiratory rate oxygenation index. This is a metric that was derived following the Florali trial in 2015, and it looked at the likelihood of intubation and failure of high flow nasal cannula oxygen. The way it's calculated is the saturation divided by the FiO2, and all of that divided by the respiratory rate. So the way we can conceptualize it is it gives us a marker of how well the patient's doing in the context of how much support we're giving them, and also how hard they're working. Now, the validation data from this was published in the Blue Journal last year, and it showed that these were the cutoff values that effectively, at different time points, predicted failure of high flow nasal cannula requiring intubation. So you can see here at 2 hours, a ROX score less than 2.85 had high specificity and a good positive likelihood ratio for predicting the need for intubation. 6 hours, 3.47, 12 hours, 3.85. And they also found that a ROX index that was ever above 4.88 was strongly suggestive of not needing to be intubated. So the way we would apply this is if they have a score shown here at those time points, that would be criteria to consider at least escalating to intubation. And if they had a ROX score over those values or ever over 4.88, we'd be able to observe them. The other component I mentioned was prone positioning, non-intubated. This is another heartwarming picture of a patient who has a saturation of 54%, is slightly tachycardic, but also has a respiratory rate of 23, and she has been proned. And you can see that by virtue of her texting, she either likely has single system issue with no shock and minimal work of breathing, or she's just a teenager. So we're considering using this in this situation. The other question that potentially could follow this is there any experience with this? Well, last week at CCTC, there was a gentleman who was on an FiO2 between 70 and 90%. And shown here is their PF ratio over time. So the first arrow points to a PF ratio less than 100, which would be generally considered severe and indication for invasive mechanical ventilation. However, this was followed by proning, and you can see the PF ratio more than doubled. There were 3 more instances of proning, and the last one you can see didn't work until the patient blew his nose, and then we did have an improvement in the PF ratio. There are also limited data preceding this pandemic that prone positioning, even during non-invasive ventilation, is effective. So just stop for a quick break to show again also mandatory COVID memes. So we can see here, this is violating principle number 5 of having too much graphics. I couldn't get the sound rigged up for Cardi B, unfortunately, but that's probably my favorite. The top left is sent from Twitter from Peter Brindley, who's an intensivist in Edmonton, of a car in their parking garage yesterday. And I think the other 2 are fairly self-explanatory. Okay, so then once we've decided that a patient has not succeeded or not managed to avoid intubation, how is that going to look? So now I'll commit another sin of an overly complex diagram. However, this is what we are currently using in the ICU to determine our steps and our protocol for airway management. Now, the vast majority of this is similar to how we would manage airways outside of the COVID situation. So I'll just draw your attention and speak to some of the changes. The first one circled there on the left with the purple circle is the personnel. So currently we're having the most experienced senior intubator alongside a nurse and an RT, with other people available in the ante room or outside the room for backup. Now, this intubation team, which I mentioned earlier, is going to be comprised of anesthetists, emergency physicians, other intubators, respiratory therapists, anesthesia assistants, so sort of smattering of people. And their rollout was supposed to be sometime this week or next, and we're still waiting for the final decision on that. But as of now, the ICU is doing the majority of the intubations. The second thing I want to draw your attention to, it's sort of different from normal, is the technique. So in order to maximize the chances of first pass success, we are employing rapid sequence induction. So this would be not a titrated induction, which is a more sort of slow, steady, and complicated procedure, but takes longer. So there's a longer time for aerosol generation. And we're also using the video laryngoscope as opposed to the direct in order to minimize the distance between the provider and the patient. A lot of the preparation is done outside the room. And then the last thing I want to draw your attention to is in the realm of avoiding accidental disconnections. So I don't have a picture, but effectively what we're doing is rather than inflating the cuff and bagging as we normally would with Untitled, teed in, and then having to switch the connections multiple times, we will be putting the ventilator circuit in line with the filter, in line with Untitled CO2, and then hook that directly up to the patient after intubation so that we minimize the amount of disconnections. Another innovation, which we're hoping to get sometime this week or early next week, are plexiglass or acrylic intubating boxes. There's an excellent video on the New England Journal of Medicine website from last week for anybody interested, where they had a balloon explode in a dummy's mouth and then put black light on the intubator to show the differences in dispersion of aerosols. So we don't have experience with this yet, but it's on the way. In terms of ventilation, I'll try and summarize our approach, but it certainly continues to be an evolution. The other thing that's dynamic with this approach to ventilation is trying to understand whether the patient fits into that H or L phenotype, because the therapy, as explained previously, will be quite different. So the first component once a patient's intubated is to establish ARDS-net ventilation or lung protective ventilation. Now, this is fairly standard in the management of intubated hypoxemic respiratory failure patients. The components here are a generally slightly lower tidal volume, so 4 to 6 milliliters per kilogram of ideal body weight. We will aim to have the lowest FiO2 that we can in order to achieve saturations above 90%. We will use plateau pressures, or target plateau pressures less than 30 centimeters of water. We'll try and have a driving pressure of less than 15 centimeters of water. And we will use bicarbonate as well as optimizing the respiratory rate up to 35 in order to manage their expected hypercapnia that results from the low tidal volumes. The other component to ARDS-net, which is really the evolving piece, is how much PEEP we provide. So from my experience, PEEP is on every exam at every level. The answer in med school for hypoxia is to give PEEP. Every internal medicine exam, the answer is to give more PEEP. And then in critical care, we talk about optimizing PEEP or recruiting. So what does this actually mean? Well, we know that in those L-type patients who have low recruitability and their hypoxemia is predominantly on the basis of vasoconstriction, that high PEEP will do nothing to improve their oxygenation as they don't have much shunt. And all it will do is expose the right heart to deleteriously high pressure. So we want to avoid over-distending or providing too much positive pressure to these patients. Conversely, in patients who have the H phenotype, they're highly recruitable, and we want to identify this and provide lots of PEEP. Now, I'll explain some of the metrics and the ways in which we're going to assess PEEP target, but it involves the use of multiple things such as measuring their pressure volume characteristics. We can measure their compliance dynamically on the ventilator. We can use esophageal balloons and esophageal manometry, and a few other techniques which I'll talk about. So every patient we placed on ARDSNet will have their PEEP optimized and decide on recruitment, and then we would monitor their blood gases. And in patients in whom we cannot achieve a PF ratio of greater than 150, and patients in whom we cannot get them synchronous with the ventilator, or in whom we cannot achieve low tidal volume ventilation, then we would initiate deep sedation, paralysis, and finally proning. So this is a graphic showing the effects of proning. This was shown in the Perceiva trial to benefit patients when it's applied early on in their course, ideally as soon as possible, and we'd be looking at doing this within hours of intubation if they met the criteria, and lasting for at least 3 days. So what you can see on the left is the distribution of air on the bottom and perfusion on the top. Generally, patients with ARDS, especially that H phenotype, have deeply or densely consolidated posterior lobes, and their anterior and apical sections are well ventilated but poorly perfused. So we prone the patient, and this achieves a number of things. It improves our ventilation perfusion matching by providing ventilation to those well perfused areas. It improves our functional residual capacity, and it also allows better secretion management and reduces the weight of the heart on the lungs. So we would do this fairly shortly after intubation and continue it for at least 3 days, ideally. The other therapy, which we are currently not going to be using during the COVID epidemic, is ECMO, and this is on the basis of its fairly poor evidence, especially in this circumstance, and difficulty deploying in a pandemic with resources as they are. So I mentioned some of the tools to assess PEEP. I just want to explain a little bit of them. This is one thing that we have with our Hamilton G5 ventilators, and this is an esophageal manometer. So on the top graph, you have time on the x-axis and airway pressure as measured by the ventilator on the y-axis. In the middle, we have the esophageal pressure. So this is a small catheter that's placed about the level of the left atrium in the esophagus. And we can measure the pressure there, which estimates pleural pressure. And on the bottom, we have the difference between the airway pressure and the esophageal pressure. Now, patients with airway pressures that are lower than esophageal pressures, so they would have a negative transpulmonary pressure. At the end of expiration, they would have collapse or atelectasis if their airway pressure is less than their esophageal pressure. So essentially what we want to do is titrate the PEEP to have a slightly positive transpulmonary pressure at the end of exhalation. Another tool which we're using on our Hamilton ventilators is the pressure volume curve tool. So this is kind of busy, but I'll try and explain the salient components. What is here is a graph of pressure on the x-axis and volume on the y-axis. The ventilator decreases the pressure down to 3 or 4 centimeters of water on the far left of the screen over here. And then every 2 or 3 seconds, it increases the pressure by 3 or 4 centimeters of water, up to a maximum of 35 to 40 centimeters of water. That's followed by deflation of the pressure, reduction of the pressure at the same rate, and then it generates these curves. So this really represents the compliance of the lung. And there are a lot of different features here which could tell us what PEEP to use and whether they are recruitable. So one that they're demonstrating here is the difference, the largest difference between the expiratory and inspiratory compliance limbs, and seeing how much that tidal volume is. So a lot of tidal volume difference between the expiratory and inspiratory limbs would suggest recruitability. There's some data that suggests that we should place the PEEP a few centimeters of water below the upper inflection point in order to maintain open lungs as much as we can. We can also leave the pressure set at the high point for 10 seconds. And then if they were recruitable, we may see this value at the top upper inflection point go up. So we can use the esophageal, the pressure volume curve for a number of things. Now, because I am from Western and in critical care, I have to talk about POCUS in some capacity. So here's this one. So this was published by Dr. Arnfield and Chest in November of 2019. And this is a video showing a patient with ARDS on a PEEP of 20. So what you can see in the starting of the image right now is the right lung is densely consolidated. This pattern is called hepatization, and you do not see much in the way of normal lung architecture. So this would be the left side as well is less hepatized, but you can certainly see only a B-line pattern indicating increased lung water. So what they would have done here is switch the patient to a higher PEEP. So you can see here at a PEEP of 30 after 10 minutes and then 20 minutes, the effects on the lung. So for those of you who don't look at these all day, it would be generally less hepatization, less error bronchograms. There's still some B lines, but on the final images of that right side, you can see A lines, which are horizontal lines stemming from the pleura that are appearing. So we've had improved recruitment. Now, for anybody who's been in the ICU, a PEEP of 30 outside of a recruitment maneuver is fairly high, but we found, especially in some patients, that estimating their recruitment, even by X-ray, is fairly challenging. So this is done through a transesophageal probe. However, it's also potentially possible, depending on the patient's character or physical stature, to do this through transthoracic ultrasonography as well. In terms of extubation, I thought I would show you a video. So trying to violate SIN number 5, which is too much graphics. This comes from Mount Sinai Hospital in Toronto. It's from Stephen Lipinski, who's an intensivist there. What they're doing here to minimize the risk of aerosol generation during extubation is filling a large plastic bag with heliox, which is helium-rich air. They place the extubation device, which here is a non-rebreather mask, over the patient's forehead, place the suction catheter inside the bag. The respiratory therapist deflates the cuff as per normal, extubate outside the bag as it shows there, and perform the necessary care and suction and remove the entire bag with the contaminated components inside it. And this is really as a measure, as a way to reduce the aerosol generation and protect our staff. We have had success with this at both sites. The one limiting factor we've noticed, not surprisingly, is patients who have claustrophobia, in which case we've just extubated them to high flow oxygen without the use of the heliox bag. So that's the majority of what we're doing right now in the ICU. I'll talk about a few of the sort of future considerations or directions that we are considering. So the first one is trying to predict that second phase of the biphasic response I mentioned at the beginning. So we don't want to extubate people who are rapidly deteriorating or will eventually get worse despite looking decent at the time. So wondering whether there's a role for routine daily CRPs or ferritins. This is something we don't know, but we're certainly considering and looking at what inflammatory markers might be helpful. We have noticed anecdotally, as well as what's shared from the Twitterverse, that coagulopathy appears to be a real concern. And this is specifically or mostly noticed when we're running patients on continuous renal replacement therapy or CRT, with the requirement of filters clogging much more quickly than they normally would. So one of the discussions is around whether we should be anticoagulating these patients more broadly, especially who are on CRT, But even in those patients who have high D-dimers or evidence of worsening coagulopathy, whether they should be on unfractionated heparin. And there's even been discussions about retrieving activated protein C or Zygris, which was previously used in septic shock, and see whether there might be utility in this disease. Something that we talk quite a bit about is the resource scarcity, and a question is always around what I'm calling polyventilation here, or using one ventilator for multiple people. This has been tried in various places. There are a number of contests going on, one outside of Montreal in terms of a design and innovation contest. And I guess I'll summarize by saying we're waiting to see if more robust, safe, and realistic models come out. Dr. Lisa and I were on a call with Mount Sinai in New York 2 days ago, and they showed us their device, which they had jury-rigged. And it initially used garden hose valves to regulate the flow going into each individual patient. And they'd updated that with a proprietary 3D printed valve. But suffice it to say, they used the word extreme, or the words extremely dangerous multiple times in their presentation. It seemed like it was far from being something that we could implement right now. We are, however, looking at converting the non-invasive ventilators that we have, so the Stellar machines on the floor, as well as the V60 devices and A40s, so that all of the BiPAP devices we have can be modified in some capacity to deliver invasive ventilation should that need arise. And the other component that's in development is the consideration of a triage protocol for a pandemic. This is occurring at the provincial level, and there's nothing specific that we've rolled out yet, but there is a protocol in development, and should we reach the point where we are unable to provide the standard of care to the patients we normally would in terms of deciding how we allocate resources, there's something in development for that. So in summary, COVID pneumonia is presenting as a spectrum of hypoxemia as well as work of breathing, and often in a discordant manner, which seems to be different from other types of viral pneumonia, such as influenza that we typically see. The phenotypic differences we're seeing from the L and the H, and also the spectrum of disease with the biphasic spike in severity, are certainly pushing us to consider a variety of non-invasive therapies, as well as some new metrics to look at. And we've also modified some of our technical procedures in an effort to minimize aerosolization and decrease the risk for our frontline providers. So with that, I'd be happy to take any questions, and thank you for having me here.
Thanks very much, Dr. Cameron. I'm going to read some of the questions that have come on the group chat, and perhaps you can address some of those. The first question was, I guess it was